Welcome back, everybody. Thanks to our previous speakers, I thought Leon did a terrific job in telling us what we can do once people have got the disease. But what I'm talking about is getting to not have the disease, which, apart from avoiding all human and bat contact, is to take on board a vaccine. Can I have the next slide, please? So the story starts in January 2020 when the genome for the virus, as it was then called, 2019 nCoV, was published, and that gave us an immediate view of the virus and what can be done about it. You've seen some of those slides and some of the the RNA from Serapit this morning, so I'm not going to go any further. But if we go to the next slide, once we have the shape of the virus, then we can start to do something about a vaccine for it. Now, historically, inactivated attenuated strains of viruses have been very successful in the past century, with a number of diseases treated. In the 1980s, the genetic engineering revolution provided purified proteins of particular viruses, which were also very effective. But more recently, we have the two strands of messenger RNA and a viral vector. Now, in researching this topic, I was surprised to find that there's actually quite a lot of data on these technologies already existing way before COVID appeared. Work has already been able to pop messenger RNA inside a lipid microparticle and use it to try to treat influenza, Zika, and cytomegalovirus. Now, there's lots of in vitro and animal data on this front. Likewise, there is lots of data on engineering viruses to make them non-antigenic and to insert in those viruses. Backwards, please. Back, please. Thank you. Yes, so there's, well, to cut to it, there's a lot of talk of our colleagues in industry going from 0 to 60 in 5 seconds, but this wasn't exactly the case, as there was an awful lot of technology out there with the ability to generate new viruses. And indeed, within several months of the genome being published, there were over 200 in development, rising 2 years later to getting on for 400, of which 7 have been validated. Next slide, please. And what I'm going to talk about in the next 10 minutes or so is the first 4 vaccines to come to market. From left to right, we have the Pfizer-BioNTech, the Oxford-AstraZeneca, the Moderna, and the Johnson & Johnson and Janssen product, also called the 3Js. So the first row just shows the number of the clinical trial and when it was started. And if we first concentrate on 25th of February, that's getting on for 6 weeks from the genome being published to Moderna saying they are going to drive a trial. That's an astonishingly short time for all the in vitro and animal work required to show that their virus showed promise. The trials were reported early in July on the 14th for the Moderna and shortly after for the Oxford-AstraZeneca. Now, we have 2 different types of product here. The BNT and the Moderna are both messenger RNAs inserted into a lipid particle, and the Oxford-AstraZeneca and the 3Js are engineered viruses. So there's a slightly different type of trials. Nonetheless, the trial size is given in the next row, not large numbers. This trial was not designed, these trials are not designed to determine efficacy. They're designed to look for side effects and for the generation of antibodies. Now, the Oxford-AstraZeneca trial was thorough in actively looking for different types of local and systemic side effects. The other trials, not quite so much. But the problem we have from the first point of view is the bottom row. The definition of the efficacy of these products varied enormously. Some of them looked at binding to different parts of the spike protein. Some of them looked at binding to the receptor binding domain. Some looked at virus neutralization, etc. So we've got a problem here with the inability to compare trials because they looked at different aspects to tell us whether or not their vaccine actually worked. Next slide, please. So the phase 1 and 2 trials were successful, and trials moved to phase 3 in people in the real world in trying to prevent them getting the disease. This table is laid out in the same way from left to right. Top row is the mean age of the participants, which is right about 52, except the Oxford AstraZeneca trial didn't give us an exact age, only those people in certain age ranges, but I perceive that that total age is slightly lower than the other three trials. Next is the sexes, which are all pretty much the same, except that, again, of Oxford and AstraZeneca, which was trialed with a great deal of healthcare professionals, which of course are mostly women, and that's why the sex ratio is very much in favor of women in this trial. Obesity is addressed in the next row. There's a great deal of it in the subjects in the Pfizer-BioNTech trials, less so in the other three trials. Coexisting conditions, of course, a fifth of patients in the Pfizer-BioNTech had some other problem, rising to 41%, almost double in the 3J trial on the far right. But in the middle, we have the Oxford, AstraZeneca, and the Moderna trials. I've asterisked those because they precisely describe the cardiovascular disease, respiratory disease, and diabetes, whereas Moderna have listed the risk factors for COVID-19 from the lung perspective. So that were people with asthma, bronchitis, emphysema, and chronic obstructive pulmonary disease. The next row is the size of the trials, very respectable. Oxford AstraZeneca somewhat lower, and once more we have another problem with the definition of efficacy ranging from 66% on the far right to 95% on the left. Again, this is because the trialists chose slightly different endpoints: symptomatic, asymptomatic, entry to hospital, entry to ICU, death, and also at what time point do they start to collect endpoints: 2 weeks, 3 weeks, 4 weeks. So there is variety in these kind of trials, 3 of which were multinational and 1 of which was just in the USA. So these 3 trials all received assent by the UK and the WHO. The Americans failed to approve the Oxford AstraZeneca trial. But if we move now to the next slide, please. There are other viruses around, and here is half a dozen of them. On the left is the nature of the virus, and there are 3 inactivated viruses. So this is a new type of virus altogether. There is a type which relies on the spike protein being produced by genetic engineering, and then 2 more of an adenovirus nature, similar to the Oxford AstraZeneca and the 3J's study. Case control numbers are given there in thousands, and the next column is of the mean age, which varies from 36 to 47, a considerable difference, and the proportion of men and women, which also varies enormously. Next column is the claimed virus efficacy, and again we have the problem of difficulty of comparison because of the variety of endpoints. And on the far right, the date that the product was approved by the World Health Organization. But bottom right, I put in, what's going on here? I tried very hard in the last few days to find World Health Organization, American FDA, our own MHRA, or the European Medicine Agency approval for the Russian COVID vaccine Sputnik, but was unable to find it. Okay, next slide, please. So now I want to move to real world trials. This is data from studies in Scotland, where over 2.5 million people were vaccinated with either the BNT or the Chadox vaccines. The first, published in the Lancet, used an endpoint of reduced hospital admission, which at 28 to 34 days was slightly in favor of the BNT product. But going only a week beyond that, curiously, the protection offered by BNT fell to 78%, whereas it rose slightly in the Oxford AstraZeneca study. If you look at the second paper in Lancet Respiratory Disease, again the same layout, BNT on the left, Chadox on the right. There were 593 deaths from 843 people, and 603 hospitalizations or deaths from 1.73 million people, which is an extremely significant difference. And by subgrouping these 2 major viruses by age, the column on the left the increased risk of an outcome increases with age, unsurprisingly. Older people are more ill and they tolerate the virus badly. Whereas on the right, only the over 80-year-olds are at risk of hospitalization or death following the Chaddox vaccination. Looking next at sex, taking females as the reference, then there's an increased risk of an outcome if male on the BNT, whereas not so on the Chaddox trial vaccine. And finally, smokers right down the bottom. If you're a smoker, having had the BNT vaccine according to this protocol, you're at risk of hospitalization or death, but not if you're in the group which was taking the Chaddox swan virus. So surprisingly, it seems that the AstraZeneca product seems to be preferable from this simple definition. Next slide, please. Lopez, Burnell and colleague published in the BMJ, looking at over 150,000 people aged over 70 who reported symptoms, assessed 28 to 34 days after vaccination. And for the BNT product, there was an odds ratio of 0.39, giving a virus efficacy VE of 61%. Data which is almost exactly the same as in the Chaddox data, 0.04, and a virus effectiveness of 60%. Now, this contrasts somewhat with the lower study from over 1,000 Californians who were considerably younger. And here the researchers looked at two different types of messenger RNA vaccines, the BNT and the Moderna, and they also found effectively no difference. But this data also points out the virus efficacy is worse in the older group than in the younger group, again underlying that the biggest risk factor for most things is age, and the virus is no respecter of the elderly in this particular respect. So that's kind of the good news in prevention. What about some bad news? Let's move to the next slide, please. Okay, vaccination can be bad. There can be pains and aches, etc. And this is data lifted from the UK Summary of Product Characteristics, which just shows the frequency of different types of side effects from very common down to exceptionally rare. And I've deliberately lifted 4 keywords there: myocarditis, thrombocytopenia, thrombosis, and anaphylaxis, because they are important. It's certainly not all plain sailing. Can we go to the next slide, please? And this is some data on the frequency of clinically relatively minor side effects. Clearly, they're not minor for the people involved, but from the hospital point of view, they're not so bad. Certainly, the 2 trials, Pfizer and Moderna, and Janssen show different data sets, and I've italicized the 3J study on the far right, because in each instance, there's a reduced frequency of these side effects in the viral product compared to the mRNA product, which I'll come back to shortly. Next slide, please. Yes, things can get bad, but it could be worse. In a study of over 48,000 people who were vaccinated, 22.6 reported an adverse side effect when given a SARS vaccine. That is exceeded by those who were given an influenza vaccination and those given a herpes zoster vaccination. So at least that's some good news from the vaccination point of view. But a meta-analysis study of 268 million people who were given a virus found 227,000 had a major adverse event at a rate of 0.08%. And that's comparable to the figure of 1.8%, which at the time was the case fatality rate defined by the World Health Organization. But that was for death. If we look in detail at these 227,000 people, we find there are only 4,000 deaths, a frequency of 0.0015%. Now, this represents less than 1.1% of those who died from the infection without any help. It followed by reverse that those who on a vaccine, although some died, 99.9% survived their vaccination event. Okay, next slide, please. So let's come back to those 3 key words I mentioned earlier 3 slides ago: allergy, myocarditis, and thrombosis. Yes, vaccination can be great, but it isn't great for everybody. There are instances of systemic allergies of 1 to 5 million people in any vaccination, let alone that for COVID. However, the Pfizer-BioNTech and the Moderna mRNA vaccine also listed a number of cases of hypersensitivity and anaphylaxis, and it's quite possible that this is due not so much to the messenger RNA, but to the lipid component of the, of the nanoparticle that was used to deliver the messenger RNA into the body. Looking at myocarditis in the general population, this appears at a rate of around 13 per million. But if you have a COVID infection, the likelihood is it would rise to 40 per million. But the estimated rate for myocarditis in those who have been vaccinated with the AstraZeneca, the Pfizer-BioNTech, or the Moderna vaccines is considerably less. So more good news as far as protection from a major side effect of COVID is explained in this particular slide. Moving to thrombosis. Oh, sorry, previous slide, please. There we go. COVID brings a big risk of pulmonary embolism of 15-fold, which falls to less than 10% of that by vaccination with BNT or the Chadox. And a further study reported the post-vaccination events of central venous sinus thrombosis from 2.2 million people at a frequency of 0.00014%. 3 slides previously, it was 10 per million, considerably less than, considerably less in those who were given the vaccine. Next slide, please. And the third aspect of bad news as far as vaccines are concerned is vaccine-induced thrombocytopenia and thrombosis. So certainly the Oxford AstraZeneca and the 3J's products bring a risk of this particular event at a very low frequency compared to many other instances of vaccinations. Now, there isn't a great deal to compare this VIT, as it's now known, vaccine-induced thrombocytopenia and thrombosis, but the nearest we have are immune cytothrombocytopenic purpura and thrombotic thrombocytopenic purpura. Now, these present at a much higher frequency in the general population compared to that which is a side effect of AstraZeneca. And our colleagues at NICE have released a guideline on the diagnosis and management of this particular problem. So yes, viruses are great, and we can't escape the presence of adverse side effects, but I hope I've shown you that these side effects are in many cases less than what would have been expected, and certainly prevent a great deal of problems in COVID-19. So can we have the next slide, please? So the vaccine was rolled out in the general population a little over early in January 2021, a couple of years ago, stratified by those at greatest risk of an infection, residents in a care home and their staff, those aged over 80, and frontline health and social care workers, and then progressively younger groups of individuals, those of 75 and then 70, and those deemed to be extremely vulnerable to COVID. You're immunosuppressed with severe respiratory disease and metastatic cancer, and then getting younger and younger and including more and more risk factor groups. So was all this effective? Let's look at the proof of the pudding in the next slide. As early as May 2021, that's 5 months into the vaccination cycle, the NIH in the USA estimated that vaccination had prevented nearly 140,000 deaths. And at 9 months into the vaccination program, our own Health Security Agency estimated that 123,000 deaths, 230,000 hospitalizations, and around 24 million infections would have been prevented by vaccination. Very powerful data indeed. But let's go abroad in the next slide. This is data from Israel with a population of around 9 million. Going from left to right across the top of the table, these are data on the number of SARS-CoV-2 infections, the related hospitalizations, if these hospitalizations are severe or critical, and if they cause death. Now, their bioinformatics experts estimated in the first row an estimate of the number of these events in the pre-vaccination period in 2020. So they expected to find getting on for 500,000 infections and not almost 27,000 severe or critical hospitalizations. What they actually found in the vaccination period, once people had been vaccinated, considerably fewer endpoints in each of these 4 columns. So that the bottom row shows an estimate of the numbers of saved events, 158,000 fewer infections, almost 25,000 fewer hospitalizations, and over 5,500 fewer deaths. So certainly there's a great deal of effect there, but 2 doses are effective, but are they enough? Next slide, please. It was noted that there was still a high number of events despite people being fully vaccinated. It was also noted that titers of antibodies to the virus fell with time, and there were concerns regarding those who were heavily immunosuppressed. This led to many anecdotal results of the effects of further boosting vaccinations in patients, which saw levels of anti-spike antibodies rise in renal transplantation and in general immunosuppression. So all of this data prompted the probability that a further dose would be beneficial. Next slide, please. This was tested in a number of more formal trials in the heart and in trials of people with various organ transplants. The first one of a heart, pre-boosting, only 23% of patients had seropositive antibodies, rising almost 3-fold to 69%. Likewise, antibody titers increased about 9-fold, and the antibodies to the receptor binding domain increased 3-fold. A second study showed that seropositivity increased by 50%, and the anti-spike antibody titers increased by 7% from one single extra boost of a vaccine. In a randomized trial at the bottom of the slide, 60 patients with various organ transplants per group showed the seropositivity increased much higher in those randomized to vaccine, so did the median virus neutralization, and so did T-cell responses. So we all know that a further boost was effective in those at greater risk. What about other populations? Next slide, please. But before we go any further, there's a great deal of talk that the natural infection with a COVID counted as a genuine vaccination, which does have some scientific credibility. So it was suggested that the second dose was not necessarily required. This is called hybrid immunity. Nevertheless, a formal third vaccination protocol was rolled out in the autumn of 2021, the same risk groups as before, and formal trials showed improved antibody generation. But why stop at 3 doses? Why not a 4th? This was studied in 12.5 million people over 60 in early 2022, and per million, those on 3 doses had 39 cases of severe COVID with over 3,600 infections, but 4 doses reduced this enormously to 15 cases of severe COVID and only 177 confirmed infections. So based on this, there was a 4th dose rolled out in the autumn and summer of 2022. But what about uptake? Who was actually taking this virus? Next slide, please. And this is a slide of the uptake of vaccination by the eligible population. So it excludes children and people who are generally unable to take the vaccination. The top solid black line shows the first vaccination, the dashed the second, and the dotted the third. And first thing to note is that these lines fail to reach 100%. The peak of the first vaccination was 94%, fell to 88% for the second boost, But the third, only 70% of people were vaccinated. Since by definition, people having the third dose must have had the first and second dose, this therefore is, depending on where you take your cutoff point, 18% or 24% fewer people who came forward for their third booster are these vaccine hesitant. That's an area I prefer not to move to. But next slide, please. In moving forward with different types of vaccination, there was a problem with supplying viruses to certain populations, and this was got round by giving a second vaccination of a different type than the first vaccination. This is called heterologous vaccination, and this showed in each particular case an improved response to a heterologous vaccination compared to homologous vaccination, to which any immunologist would say, oh, surprise, surprise, this is a well-known fact. And pressing on to the next slide, please. It's been hinted in Sarah Pitt's talk and also on Leon Peters' talk of the problem with variants. The trouble is there's a huge amount of data out there. Some of it says we're in trouble, and some of them say it's not as big an issue. But certainly there is therefore a need for updated vaccines. Next slide, please. And Pfizer, BioNTech and Moderna have on the market a new type of vaccine, bivalent vaccines, which include not only material from the ancestral Wuhan strain, but also from Omicron viruses. In some cases, it's the BA.1. In some cases, it's the BA.4.5. These are now approved and are likely to be rolled out in the spring and summer of this year. Hopefully, they will give added protection against Omicron. And a new entry to the market from Sanofi GSK, a new type of recombinant protein vaccine given with an adjuvant. This is approved just before Christmas and is also listed for spring 2023 booster. So there's lots of new vaccines on the way, and this year we'll certainly see the use of each of these three in our populations. And my last slide, please. So certainly we're going to see rolling booster vaccinations, certainly in the spring for those aged over 75, resident in a care home, the immunosuppressed, and then perhaps the rest of us, I hope. But to what extent is COVID still a big deal? Data from the Office of National Statistics show that deaths involving influenza or pneumonia exceeded those of SARS-CoV-2 every week since January 2020 by over 1,000 patients per week. And deaths due to influenza and pneumonia exceeded those of the COVID virus every week since May 2022, except perhaps 8 weeks, and every week since 18th November to a median of 310 deaths. So there's certainly a great deal less COVID death than there was. And in the distant future, perhaps there will be nasal vaccines and aerosols delivering virus particles directly to the lung. And what's next for me? I hope another booster, and also for me to wind up. Thanks very much for your patience. Back to you, David.